Good evening to all. So today we will be discussing about in-hospital management of hyperglycemia, or in other words, diabetes management in inpatients. So of late, this is a more important clinical topic which is required for clinical clinicians who practice in a private setting or a government setting or a corporate hospital. Wherever you practice, this topic will be of immense help to you after this COVID-19 infection. After this COVID-19 infection, we have seen lot of patients admitted with very, very high blood sugars like 400, 500, 600, very difficult to manage cases. So it will be very helpful if you keenly go through this topic slide, each and every slide by slide. So today we will be discussing about the impact of diabetic patients after getting into the hospitals and how to manage hyperglycemia in medical as well as surgical ICUs, and how to switch over from IV insulin to subcutaneous insulin, followed by management of hyperglycemia in non-ICU settings, followed by some special situations, finally the conclusion. So diabetes is becoming very, very common, as told by our chairperson, Dr. Madhusudanan. It is very, very rampant nowadays in India. More than 70 million people are being affected by diabetes all over India. And worldwide, it is around 450 million people who are suffering from diabetes. So for each and every patient you detect with diabetes, there goes one patient who is being undetected with diabetes. So most of the people are roaming around without being detected that they are diabetes. They don't get a chance to detect diabetes. Only after getting admitted to hospital or coming to hospital for some other treatment, we detect diabetes in those patients. Likewise, every sixth patient admitted to the hospital has diabetes. And diabetes has contributed to around 8.2% of hospitalization and 15.6% of inpatient deaths. Even in our hospital, it's similar. The statistics are similar to this. And intensive insulin therapy has demonstrated to decrease the mortality or morbidity in critically ill patients like our COVID-19 patients. So the in-hospital hyperglycemia can be of three types. One is a patient who is known diabetic, already on treatment, coming to the hospital, and other category is a normoglycemic category, and the third category is the new onset hyperglycemia, which has been detected only after admission. So now what is the difference between these three types? So the normoglycemia people always goes normally without any complication as far as glycemic levels are concerned. But when you compare the patients who have who have been already on treatment for diabetes and who are being detected newly after admission to the hospital, this new onset diabetes people have higher mortality and morbidity because they are not at all under treatment before admission. They are likely to have very high blood sugar levels after admissions. Those patients who are known diabetic would have been on some tablets or insulin prior to admission, and their glycemic levels are not that high. And even if it is very high, they are easily controllable. But this new onset diabetes could be easily missed, or even if detected on day one of hospitalization, we need some time to get control over the diabetes. That's why the mortality and morbidity rate is very high in patients who have new onset diabetes. So this is another article from Clinical Endocrinology Metabolism, where again the total inpatient mortality is very high. That is around 16% in patients who had new onset diabetes after admission to hospital, when compared to that of known diabetic patients, where it is only 3%. So now coming to the causes of hyperglycemia after the patient is getting admitted to the hospitals. There are multiple reasons for high blood sugar levels after getting admitted to the hospital. The first and foremost is the withholding of oral antidiabetic agents and giving some other drugs like glucocorticoids or vasopressors in the ICUs. So that could lead to hyperglycemia. The second factor is the inconsistent food intake, like untimely or irregular meals. Enteral nutrition and parenteral nutrition could elevate the blood sugar levels. And the third one is the physical and medical conditions like stress of the infection, stress of trauma, and infections could lead on to hyperglycemia. So now moving on to the topic proper of how to manage hyperglycemia in inpatients, that is particularly critically ill patients who are admitted to ICU. Here you can categorize again the patients with known diabetes, undiagnosed diabetes, and hospital-associated diabetes. So hospital-associated diabetes could be either iatrogenic or stress-related. Iatrogenic comes under the category of hospital-associated diabetes because we use some of the drugs like glucocorticoids or other vasopressors to treat the patient. So that could be the reason for iatrogenic hyperglycemia. And stress-related diabetes is very common in patients who are admitted with head injury and myocardial infarction and stroke. The stress of the underlying condition itself will raise the blood sugar levels because the counter-regulatory hormones are very, very high in these patients. But whatever be the underlying cause of hyperglycemia, it has to be treated always. Whether it is a known diabetic patient or newly detected diabetes patient or iatrogenic diabetes or stress-related diabetes, all these hyperglycemia have to be treated with insulin. So now what's the role of A1C in patients who are admitted to ICU? So there is not a great help with the A1C. We are not going to use A1C for your day-to-day blood sugar management. But anyhow, it will be of some helpfulness when it will be helpful in assisting with the differentiation of a newly detected diabetes from a stress hyperglycemia. Because in a newly detected diabetes, the A1C levels should be more than 6.5 or 7, whereas in stress hyperglycemia, usually the blood sugars alone will be very high, whereas the A1C levels will be less than 6.5. So that's how you differentiate between newly detected diabetes and a stress-related diabetes. And it will also help in assessing the glycemic control prior to admission. Suppose if the patient is admitted, has a high HbA1c of like 11, 12, or 13%, uh, you could assess the outcome of the condition for which he is admitted. And it will also help in designing an optimal discharge regimen at the time of discharge with the help of HbA1c. If the HbA1cs are very, very high, then you need to discharge the patient on insulin until the HbA1c comes down to a favorable level. So earlier we thought that very intensive glycemic control will be very helpful to the patient. But the NICE sugar study, which was the largest RCT, which was conducted in critically ill participants, around 6,104 patients were involved in this study. Contrary to our belief that intensive glucose control is going to be of much helpful, here this study came out with a different report. So here they saw a higher mortality rate in patients who were treated with intensive glucose control. Intensive glucose control means they will keep the blood sugar levels between 80 to 108. So that was the level of blood sugar they were aiming to manage in intensive glycemic control group, whereas the conventional group had blood glucose control of between 140 to 180. So at the end of the study, they found that the mortality rate was very, very high in the intensively controlled group because of severe hypoglycemia. So after this study came, there were a lot of changes in the guidelines. So you can see that the guidelines which were proposed in the ADA 2015 had a greater change. Like you concentrate on the last but one line where ICU. So the ICU targets were 110 in the year 2004, but it's changed to 140 to 180 later on. So even now we follow this guideline. These are the target range of blood glucose level in any ICU for the betterment of the patients. It is only 140 to 180. It is never 80 to 108. Earlier it was 80 to 108, but after this NICE sugar study came out, it has been changed to 140 to 180 in majority of the ICUs. But in selected ICUs like post CABG cases and post wound debridement and other infectious cases, you could you could again tighten the target to 110 to 140, but it is not again 80 to 108. when you aim for a target of 80 to 108, the mortality rate goes up again because of severe hypoglycemia. So now what you are going to do when a patient is getting admitted to the ICUs with high blood sugar levels? So it is nothing but you are going to recheck the blood sugar level if you are in doubt, and you are going to start the patient on insulin infusion, and you are going to keep the blood sugar levels between 140 to 180. So this continuous IV insulin infusion should be the standard of care for all patients who are admitted with very high blood glucose levels in your ICUs. So this CIA, that is continuous insulin infusion, is effective and targets can be easily reached, and you could able to maintain the blood glucose levels within the target range for several hours or even throughout the day. And you can make small increments or decrements in the insulin infusion rate based on the blood sugar levels. And this particular type of insulin infusion is well tolerated by most of the patients, and it has minimal risk of hypoglycemia, because whenever you give insulin as a IV, the half-life of insulin is only 3 to 5 minutes. So when the patient tends to have a low blood sugar level, if you stop the infusion, there will be no hypoglycemia. But if you give the same insulin as a subcutaneous dose, you cannot withdraw the insulin which has been already injected. But here it is not so. If you just stop the infusion pump, the patient will recover from hypoglycemia. And this type of treatment could be easily implemented and executed by the nursing staff with proper training. So how to start this continuous insulin infusion? So just see the blood sugar levels. If it is around 237, for example, if it is around 237, you start with 2 units per hour. If it is around 387, the nearest rounded number, you start with 4 units per hour. So it is as simple that most of the nursing staffs can be educated to start this insulin infusion. And there are many protocols which exist to titrate the insulin regimen. It is not only enough if you start the patient on insulin infusion, you have to check the blood sugar every hourly or every second hourly, and make modifications in the infusion rate. So to modify this infusion rate, there are multiple protocols like Degami protocol, Vandenberg protocol, Portland protocol, Yale University protocol. A lot of things are there which are very confusing to the nursing staffs and doctors, but you could follow the simple one which is given by the Indians. This is the Indian guideline, Indian consensus guidelines for insulin use in hospitalized patients. So it is very simple. You can take a screenshot of this and you can paste it in your ICUs. See, whenever the blood sugar levels are, you have started the insulin infusion rate based on the initial prevailing blood glucose level. After starting this, check every hourly or every second hourly and adjust the rate of infusion according to this chart. If it is around 550 to 599, you can infuse at the rate of 6 units per hour. If it is between 500 to 549, you can infuse the insulin at 5.5 units per hour. Likewise, when the blood sugar level comes down, you can gradually down titrate the insulin infusion rate. So at one point of time, the blood glucose levels will remain stable, and you will be infusing some 2 or 3 units per hour, like that. So initially start measuring hourly blood sugar levels and adjust the dose. Once the blood sugar level is slightly stable, you can check every second hourly or every fourth hourly and keep the insulin infusion continuously. So when you are going to stop this insulin infusion and change over to subcutaneous insulin therapy. So once the patient is stable, like the underlying condition is stable, suppose for example, you have admitted the patient for a COVID-19 infection, and the patient is now stable and ready to go out of the ICU to a general ward or to a special room, you need not continue insulin infusion in that patient. Once the patient is stable and is started on enteral feeding or oral feeding, the transition from IV insulin to subcutaneous insulin therapy can be made. So to change over from IV insulin to subcutaneous insulin, you have to give the subcutaneous insulin dose 1 hour prior to stopping IV insulin, because it will take some time for the subcutaneous insulin to mix with the blood. So it will take some time. So you have to inject 1 hour prior to stopping IV insulin. So while switching over, subcutaneous basal bolus regimen is the preferred mode of transition, and the dose of insulin in the subcutaneous basal bolus regimen has to be individualized between patient to patient. So now how you are going to calculate the subcutaneous insulin dose when switching over from IV to subcutaneous? So you should calculate the average IV insulin rate in the last 12 hours to obtain the mean hourly rate and multiply it by 24 hours to get the total daily insulin requirement. Suppose the average hourly requirement during the last 12 hours was 4 units per hours. It will come around 96 units per day. So this 96 units has to be given as subcutaneous basal bolus insulin. So among the basal and bolus, you give this 50% of this 96, that is 48 units as a basal dose, and remaining 48 unit has to be split into 3 for each and every meal, for breakfast, for dinner, and for lunch. So you have to divide this 48 units into 3 and give it to each and every meal the patient is taking. So coming to the end of this ICU part alone, insulin is the preferred therapy for treating all critically ill patients with hyperglycemia, independent of their diabetes status. So the patient is a known diabetic or newly detected diabetes or a stress-related diabetes or an iatrogenic drug-induced diabetes has to be treated with insulin only. And the target blood glucose levels in all ICUs should be only 140 to 180. It is not less than 80 or 108. So it always 140 to 180 is the standard. And best suited insulin infusion protocol should be followed. And the more easiest one is the Indian guidelines recommended, which we discussed earlier. So moving on to the management of hyperglycemia in non-ICU settings. So this is very common in your clinical practice. Like many of the patients admitted to the ward or special rooms will have diabetes, and how to manage these patients. So upon admission, assess the patient history, whether he is having diabetes or not. If there is no history of diabetes and the blood glucose level is less than 140, you could consider that the patient is non-diabetic, and if you can recheck whenever the underlying condition necessitates. And suppose that the patient is not having any history of diabetes, but the blood glucose level is more than 140, you could check the HbA1c levels. If it is more than 6.5, you start treating the patient as diabetes. And the third one is the patient who is known diabetic, having diabetes for long duration and taking tablets. You can keep on monitoring the blood glucose level and start him on insulin if the blood glucose levels are very high. So according to the ADA and the ASCE, the target glucose levels in non-ICU patients are like this. So all the pre-meal glucose should be less than 140, and all the random blood glucose or the postprandial blood glucose should be less than 180. So the blood glucose targets may be more stringent in patients who are very young and newly onset diabetes, having no complications. But in some patients who are very elderly, having all sorts of vascular complications, you could just relax the blood glucose control to still higher levels. And that could be decided based on the clinical settings. So before knowing what to be done, we should know what should not be done. So avoid sliding scale insulin therapy while treating diabetes in a non-ICU settings. So sliding scale, that is particularly the subcutaneous sliding scale insulin therapy, is discontinued in clinical practice due to non-physiological strategy with a retrospective reaction to blood glucose levels. So the sliding scale is nothing but when the blood glucose levels are only very high, the nurse administers some insulin. When the blood glucose becomes normal, no insulin will be given. Again, what happens? Because of this no insulin, again the patient takes food and the blood glucose level starts rising. Again, they give some insulin, again becomes normal, no insulin, again rising. So this becomes a roller coaster phenomenon, and you cannot predict the exact dosage requirement of the patient. So this is the most unphysiological way of treating diabetes. So earlier in those days in 1934, the sliding scale was introduced by Elliot Jocelyn based on the urine sugar testing. So that's older days, older way of managing diabetes. We are in a modern era. We have to shift ourselves from this sliding scale to the most advanced basal bolus insulin therapy. See, based on the glucose levels, some units have been suggested by the doctor, and this chart will be fixed in the uh, nurse's chamber, and the nurse by themselves give the insulin based on the blood sugar levels. If the blood sugar levels are very low, they will not give insulin. So it's a reactive approach. Upon seeing a high blood glucose only, insulin is being given. When the blood glucose is normal, no insulin will be given. So the literature describes this sliding scale as the action without benefits, mindless nonsense way of treating diabetes, all those things. See, this is an example of the sliding scale insulin regimen. For example, if the patient is having 6 a.m. blood sugar as around 200, the nurse will give 4 units, and around 10 a.m. it becomes 140, no insulin will be given, and around 2 p.m. 220, 6 units will be given, 6 p.m. 100, again no insulin, 10 p.m. 250, and the nurse will give 10 units according to the chart given to her, and around 2 a.m. the patient will go for hypoglycemia. And they will treat the patient with 25% dextrose, and because of this 25% dextrose, the morning 6 a.m. blood sugar will be 300, and the morning duty nurse, without knowing this hypoglycemia, she will again give 12 units of insulin. Again, the patient will go for hypoglycemia at 10 a.m. So this will happen if the treatment protocol is carried away by sliding scale method. So this is the most unphysiological way of treating patients. See the roller coaster effect. This roller coaster effect is directly linked with the complications in our patients. Suppose, for example, if a patient is getting admitted for myocardial infarction and the patient is getting sliding scale insulin therapy, his outcome will be very, very poor. And if the patient happens to undergo or experience hypoglycemia, the risk of death, in hospital death, will also be very high if you are going to manage the patient with sliding scale insulin therapy. So fluctuating glucose levels may be a predictor of diabetic complications independent of the HbA1c levels. So how to overcome this? You have to be more proactive in your approach. You have to anticipate major changes in the blood glucose levels and prevent them from happening. It is not after seeing high blood glucose levels, you give insulin. You have to predict that in this patient, blood glucose levels will rise after some time. So I have to give insulin previously itself. So that's the way you have to treat. So that's the that could be achieved only when you are going to follow a basal bolus insulin regimen. So how to give this basal bolus insulin regimen? So this, by definition, basal bolus insulin regimen is more physiological because the insulin secretory pattern in the normal physiological way is once you take a food, insulin is getting secreted, and again the peak insulin comes down, and again when you take lunch, again a small peak is there, and again when you take dinner, a small peak is there. So you are going to mimic this physiological insulin secretory pattern by giving basal bolus insulin therapy. Here what you are going to do is you are going to give a basal insulin which is going to act for the 24 hours, like basal insulin analogs like glargine or detimar or degludec. It will act for the next 24 hours when given at a point of time. And this bolus will be taking care of the postprandial blood sugar levels. You are going to give 3 bolus insulins with short-acting insulin analogs like Lispro, Aspart, or Glulysin. It is going to take care of the post-breakfast, post-lunch, and post-dinner blood sugar level. So ultimately, you are going to give 4 insulin injections per day in an IP patient to control the blood sugar levels. We have some evidences to show that basal bolus insulin therapy in inpatient management is better than sliding scale insulin therapy. Here, there is a comparison between the sliding scale insulin therapy and basal bolus insulin therapy. By using basal bolus insulin therapy, you could be able to achieve a target blood sugar of between 140 to 180 within 2 or 3 days. Whereas if you are going to use sliding scale insulin therapy, until 10 days, even after admission, you are not going to achieve a glycemic target. So this is again from the Rabbit-2 trial, where sliding scale insulin regimen resulted in uncontrolled hyperglycemia in some patients, and those patients who are not controlled with sliding scale therapy were switched to basal-bolus insulin therapy. Once you switch from sliding scale to basal-bolus, immediately the blood sugar levels dropped, and by the end of the 7th day, when you are planning for discharge, the blood sugar levels are more stable, and the patient as well as the doctor will be happy if they follow basal-bolus insulin regimen. So for inpatients with diabetes receiving insulin therapy prior to admissions, a scheduled subcutaneous insulin regimen is recommended in hospital settings. So you are going to use either glargine, detamar, or degludec for the basal requirements, and you are going to use regular insulin or rapid-acting insulins like aspart, lispro, and glulysin for the prandial control. So how to start with the insulin when the patient is getting admitted to the ward? So you calculate the total daily requirement. So the total daily requirement is going to vary from patient to patient. Suppose you are going to treat a geriatric patient or a patient with significant renal impairment, the total daily requirement should be calculated as 0.2 to 0.3 units per kilogram body weight. The next category, the normal body weight patients and young patients, if the blood glucose levels are between 140 to 200, you start with 0.4 units per kilogram body weight. And if the blood glucose levels between 200 to 400, start with 0.5 units per kilogram body weight. And obese patients on glucocorticoid treatment, CABG treatment, severe infections, total parenteral nutrition, start with 1 unit per kilogram body weight. So this is just the starting dose. For example, you have a patient who is 60 kg male admitted for fever and able to take oral diet, and his blood sugar levels is around 300 milligrams per deciliter. So you calculate the total dose as 0.5 units per kilogram. That is 0.5 units into 60 kg. It comes around 30 units. So among this 30 unit, 50%, that is 15 units, has to be given as basal insulin, either glargine or degludec. Remaining 15 units has to be divided into 5 units for 3 meals. 5 units for breakfast, 5 units for lunch, and 5 units for dinner. And the next day, check the fasting plasma glucose and all the 3 postprandial blood sugar levels. So based on this, we have already noted that all the preprandial blood sugars should be less than 140 and all the random sugars should be less than 180. So if the fasting plasma glucose has not come down to 140, and if the postprandial blood sugar levels have not come down to less than 180, you have to add fractional insulin doses. So you have started with 5 units of short-acting insulin for each and every meal and 15 units of basal insulin at bedtime. And until the target is getting achieved, you have to add the correctional dose of insulin or supplemental insulin to the pre-existing insulin dose based on the blood sugar levels. Suppose if your fasting plasma glucose is around 221 to 260, for a patient who is insulin sensitive, add 6 units, and for usual patients, add 8 units, and for an insulin resistant patient, add 10 units. So for fasting blood sugar to come under control, you have to add 10 units for an insulin resistant patient to the basal insulin. So basal insulin is going to control the fasting plasma glucose. So instead of 15 units, you have to give 25 units the next day. Suppose if the postprandial blood sugar levels are high, for example, if the post-lunch blood sugar level is around 261 to 300, you could again add 10 units or 12 units to the lunch dose. Instead of giving 5 units, you have to give 15 units for the lunch. Only then the blood sugar levels will come down. Likewise, for each and every value, you have to add correctional dose of insulin. So now moving on to the next topic of perioperative management of diabetes. Diabetes control or tight glycemic control is very, very essential in patients during the perioperative period. So suppose if it is a major surgery like uh, gastro surgery or cardiac surgeries, you have to treat the patient with continuous insulin infusion again. But for minor surgeries, you could treat with a small dose of insulin, and you could discontinue the tablets and long-acting insulins before the day of surgery and change over to intermediate acting or short acting insulin for relatively minor procedures like cataract surgery, which do not require any nil per mouth for prolonged period. You may continue with oral anti-diabetic agents if the glycemic control is very good. And the question regarding OAD use during preoperative period, like particularly second generation sulfonylurea should be discontinued one day before the surgery, and metformin should be withheld 1 to 2 days before surgery. And there are no recommendations for discontinuation of pioglitazone, but even then we do not use any oral antidiabetic agents prior to surgery. And patients with good metabolic control posted for minor surgery, oral antidiabetic agents could be started one day after the surgery. If the patient has some infectious wound or infectious swelling surgery, insulin has to be continued until the wound healing happens. For major surgeries, pre-op glycemic control is essential with insulin. For uncontrolled diabetes who are admitted for major surgery, use continuous insulin infusion as we have discussed in the first few slides. And during surgery, try to use buffer solutions which could maintain the blood sugar levels. And you have to take this as a first case on the day of surgery. And you have to check the blood sugar immediately in the post-operative period and again restart continuous insulin infusion. And once the patient takes oral food, you could change over from IV insulin to subcutaneous insulin. So coming to the end, for all non-ICU patients, subcutaneous insulin therapy consisting of basal or intermediate acting insulin in combination with the rapid or short-acting insulin is recommended. For all critically ill ICU patients, continuous insulin infusion is recommended. Some special situations where you need to have attention over is the TPN. It is the total parenteral nutrition. So hyperglycemia in patients without diabetes from TPN is very common, and patients who take TPN may require even 100 units of insulin per day. So that much amount of glucose is there in the total parenteral nutrition, and patients who already have diabetes put on TPN may require even up to 100 units of insulin. So maximum of 100 units could be given in the TPN bag itself. So some textbooks advocate addition of insulin to the TPN bag itself, whereas some textbooks advocate subcutaneous insulin while the patient is on TPN. So to calculate the requirement, again we have to go for subcutaneous or IV insulin infusion to know the dose requirement during TPN and then calculate the total requirement and give it as subcutaneous or adding to the bag itself. And people with different nutritional status will also require insulin, like a patient who are kept on NPO for longer duration, that is particularly diabetic patients who are kept on NPO for longer duration. Those patients will also need the basal insulin, that is the 50% of the total daily requirement has to be given as a basal insulin to these patients, even they are not taking anything by mouth. So this is the point which we miss most of the time, because we do not give insulin when the patient is on NPO. That will lead to severe weight loss because of catabolism. So the next situation is the glucocorticoid therapy, where high dose of glucocorticoids are strongly associated with increased insulin requirements. While giving steroids to these patients, particularly we use steroids for patients who are undergoing cancer chemotherapy, we should expect that hyperglycemia will happen after 8 to 12 hours after the dose of dexamethasone or methylprednisolone. And so we have to increase the dose of insulin by 25% to 30% before giving the steroid dose. Only then you could get control over the blood sugar levels. And ADA recommends that once the patient is on a high dose of insulin, you could even use IV insulin to control the blood sugar levels. So the final take-home message is start insulin as early as possible in all your critically ill ICU patients. Do not hesitate to start IV insulin infusion and follow simple guidelines given by the Indian Diabetes Association. And maintain a target of between 140 to 180 in all your ICU patients, and use Basal-Bolus regimen in all stable patients whenever you want to shift from IV insulin to subcutaneous insulin. And more commonly, do not use sliding scale insulin therapy for subcutaneous insulin injection, and give basal insulin to patients who are on NPO also for their basal requirement to prevent catabolism. So with this kind note, I like to end my talk. If there are any questions, you can type in the chat box. Thank you one and all for your patient listening.
So now we have some interesting questions in today's topics. I'll read it out one by one for the speakers to answer. The first question is, why is more aggressive control of blood glucose not advisable? Why is more aggressive control of blood glucose not advisable?
See, as we have discussed from the nice sugar trial, this is the largest trial in critically ill patients. Okay, so critically ill patients who are in the ICUs are at risk of hypoglycemia when you manage the blood sugar between 80 to 108. So 80 to 108 was considered in those days as a good level. But after the study came out with a contrary report that 80 to 108 was producing more deaths because of severe hypoglycemia. They have switched over from this more intensive therapy to conventional therapy of between 140 to 180. So 140 to 180 did not produce more mortality, but at the same time, the outcome from the ICUs were also good. The infection rates were well controlled, and the stay during the ICU period was less when compared to other range of blood glucose levels. So it is based on the study only. They have switched over from more intensive control to conventional control. So it is only with regards to ICU control. I am not talking about the OP patients where we manage very strictly with intensive glycemic control, where we need a A1C control of less than 7 in most of our patients who attend to our OPD. So that is totally different from what we had discussed today. So we had been discussing only about the ICU cases where more intensive control is not recommended.
Okay, sir. Thank you. Thanks for the answer. And coming to the second question, is there any clinical test for insulin sensitive and insulin resistance differentiation? I'm repeating the question. Is there any clinical test for insulin sensitive and insulin resistance differentiation?
See, yes, there are some tests nowadays, but we don't routinely use it for our clinical practice. So there is a HOMA analysis, that is homeostasis model of assessment, being done with certain certain parameters like insulin levels, blood sugar levels, C-peptide levels. With all these, they come out with a insulin resistance level. But in routine clinical practice, none of the guidelines have recommended to use this HOMA as a marker of insulin resistance. So generally, when seeing the patient itself, we will know that which type of patient will have insulin deficiency predominantly, which patient will have insulin resistance predominantly. So it is more of clinical rather than going to blood test. Though there are tests, but we don't use it routinely because none of the guidelines have recommended it.
Okay, sir. Thank you. Coming to the third question, how to calculate TDD insulin based on FBS and PPBS? I'm repeating the question.
Yes,
how
yes,
to
I got the question.
Yeah, okay. How to calculate? Okay, fine, yeah.
So based on the fasting plasma glucose and based on the PPBS, it is just a range we have discussed in our slides, like when the blood sugar is between 200 to 300, you calculate as 0.4 units per kilogram body weight. And if it is between 300 to 400, you calculate the total dose as 0.5 units per kilogram body weight. You have to see the weight of the patient. You have to see the blood sugar, prevailing blood sugar range. It is not the exact value of blood glucose level. It is just a range of blood glucose levels where the insulin uh, calculation slightly varies between 0.4 and 0.5 units per kilogram. So it is all just the starting dose. You have to keep in mind that it is just the starting dose of insulin. So on day one, you have to give it based on this calculation, that is 0.5 units per kilogram body weight. Suppose if the patient's body weight is around 60 kg and if the patient blood sugar is around 300, you calculate it as 60 into 0.5, where it comes around 30 units per day. So 30 units has to be given as Basal-Bolus regimen. So you give 15 units as a basal insulin, and remaining 15 units should be divided into three bolus units, three bolus insulins for each and every meal. So that's the starting dose on day one. On day two, based on the prevailing blood sugar levels, you have to adjust up titrate or down titrate the dose of short acting insulin as well as the basal insulin.
Okay, sir. Thank you. Next question. How to find PPAR gamma gene, and can you elaborate the use of that gene? How to find PPAR gamma gene, and can you elaborate the use of that gene?
Yeah, PPAR gamma is a target for thiazolidine group of drugs. But generally, again, we do not evaluate all these things in our routine clinical practice. Maybe in the research setting, they may be doing this PPAR gamma gene analysis and all those things. I think Dr. JS could throw a light on this.
Okay. Jay, sir, your answers on this.
See, basically these genes are more of research use only, as sir have told that these are for research purpose, where we find out or some when we undergo on some research during the diabetes area, where we find about the etiologies, or where we get the cases where cases are not responding to the insulin treatment or like that. These genes are studied, and the part of how it can be find out, basically it requires a complete sequencing of exome, where this gene can be particularly find out, or the mutation in this gene can be find out. So basically it is the molecular biology techniques, more of the areas of in the molecular biology or biotechnology, where these genes can be detected with the help of genome sequencing.
Okay,
so,
sir.
but I see basically, as sir told that it is not of that much practical importance as far as the clinical treatment or clinical management is concerned.
Fine, sir. Thank you. Thanks for the answer. And next question is how to get adult GTT reference range. How to get adult GTT reference range.
In my present,
actually, you can continue. You can continue.
Yeah. Actually, in my presentation, what reference range I have told, that was basically for adult only. What reference range we give in the GTT at 0 hour or 1 hour or 2 hours, they are basically adult reference range, like less than 180 and at 1 hour, less than 155 at 2 hour, and less than 130 145 at 3 hour. These are basically the adult reference range for GTT.
See, here I like to mention that GTT in a non-pregnant state is different from that of a GTT done in a pregnant patient. Okay, so in a non-pregnant state, GTT is nothing but you give 75 gram of glucose to the patient, and directly you can measure this 2-hour plasma glucose that is being recommended nowadays by the American Diabetes Association. You need not check the 30-minute blood glucose level, 1 hour, 1.5 hour values can be skipped, and you can directly go on to measure the 2-hour value. So that is the GTT which is being nowadays as per the ADA recommendation. You give 75 gram of glucose, check the second hour sugar level. So if it is more than or equal to 200, you could directly label the patient as type 2 diabetes. So this is as far as non-pregnant state is concerned. As far as the pregnancy GTT is concerned, what JS has told is rightly fitting. So it has been derived from the Carpenter and Houston criteria. So that there are many criteria to set the target for blood glucose level during pregnancy, and more commonly used is the Carpenter-Houston criteria, where you have to do a 3-hour GTT with 100 grams of glucose. You take a fasting plasma glucose, check the 1-hour value, 2nd-hour value, and 3rd-hour value. So based on this Carpenter-Houston criteria, if 2 or more than 2 values are crossing the target range, you could label the patient as having gestational diabetes mellitus.
Okay, sir, thank you. Next question is, what are the best treatment options for early to advanced diabetic neuropathy along with good diabetic control? What are the best treatment options for early to advanced diabetic neuropathy along with good diabetic control?
See, for diabetic neuropathy, the first and foremost is the good glycemic control with insulin. So it is not only good glycemic control achieved with insulin. So though you achieve a good glycemic control with oral anti-diabetic agents, diabetic neuropathy may not recover most of the time. But if you are going to put the patient on insulin, either a basal insulin alone or a premixed insulin or a basal-bolus insulin therapy, only then the symptoms of diabetic neuropathy will recover, because the diabetic neuropathy recovery rates are very high in patients who are treated with insulin. So insulin itself is a good treatment for diabetic neuropathy. Apart from providing good glycemic control, insulin will itself treat diabetic neuropathy. So for patients with the positive symptoms like tingling, burning sensation, needle prick sensation, you could use gabapentin or pregabalin at a lower dose, starting with a lower dose, gradually up titrating to the higher dose. So if you are using gabapentin, start with 300 milligram once a day to up to 900 milligrams per day. And if you are starting the patient on pregabalin, start with 50 milligram or 75 milligram once a day, and you can up titrate to 150 to 225 milligrams per day. And there are a lot of topical creams or gel-based ointments which are now available with the constituents being gabapentin or pregabalin along with lidocaine and capsaicin, which are going to stimulate the nerve endings. So they will also be more helpful when added in addition to the oral tablets. So this is only for patients who are suffering from positive symptoms. Some patients with diabetic neuropathy, particularly long-standing diabetic neuropathy, will have numbness. So that is called as negative symptom. So negative symptoms takes a long time to recover, and sometimes they may not recover even. So these negative symptoms will be more problematic than the positive symptoms. Patients who have negative symptoms tend to develop more of diabetic foot ulcers, that is the neuropathic ulcers or tropic ulcers, are more common in patients who have negative symptoms because they are not able to sense at all. They will not feel the sense of heat. They will not sense even the thorn prick or glass prick, and they tend to develop more ulcers than the patients with positive symptoms. So in those patients, protective footwears are going to be of more helpful rather than other medications. So in those patients, you have to use protective footwears both outdoor as well as indoor.
Thanking Dr. Mahesh Babu sir and Dr. Jayesh sir for spending their time with us with an elaborate and informative talk. I hope all the attendees and participants got that point. There are a lot of take-home points in their talk, and Meenakshi Mission takes immense pleasure, and Meenakshi Labs provides all the available tests that Jayesh has already listed out, except for those research-based tests, which we will be taking steps to provide shortly. I thank the management team of Meenakshi Labs who take immense steps to bring out this upgrade program every month. I thank the coordinators of this upgrade program, the marketing team, the comparer, the EDP team for the connectivity and the hardware connected to it. And last but not the least, I thank all the participants who have been there till the end, patiently listening to the talk. Thank you all.